I agree. Thank you for everyone to help and getting this all set up. And obviously, I appreciate the opportunity to present today virtually. And I apologize for not there to be in person, but I'm glad to be given sort of the opportunity today to talk a little bit about circulating tumor cells and circulating tumor DNA, specifically in the context of uveal melanoma. And as mentioned earlier, my name is Dr. Ben Sma, one of the faculty at the University of Wisconsin-Carmel Cancer Center. So these are my disclosures. So, one of the things in terms of the dilemma that we're facing right now in terms of how we typically assess a patient's disease status with regards to their cancer is that the typical standards will use radiographic imaging, specifically imaging like CT scans, PET scans, MRI, to actually evaluate and determine the location and the extent of disease. But we know that there are several limitations of using some of these imaging modalities or these scans. For example, is that these scans can sometimes be quite costly and can incur a high copay for patients. We also know that these can be quite time-consuming as well, in the sense that we have to create a separate appointment for patients to get their scans prior to their oncology visit. There's also the risk of having patients undergo some degree of low-dose radiation in order to get these scans completed. Sort of at the burden or the limitations of what insurance allows, we can't perform scans as frequent as we would like to monitor a patient's disease status, especially when they're on therapy. And then for patients who, for example, may have allergies to contrast or dyes for these imaging, that also limits the ability for some patients to get these imaging done. And so, why is this particularly important, especially in the context of uveal melanoma, is that there is some suggestion over the years that using some of these standard imaging or scans may not actually be the best tool to evaluate whether or not a metastatic uveal melanoma patient is actually benefiting from treatment. And so nowadays, the availability or the FDA approval of KIMMTRAK or Invasive, we know that the response or the actual tumor shrinkage of the tumors only occur in about 5 to 9% of patients who are treated with this therapy. But what we've also learned is that when we look at these patients who have growing tumors despite therapy, they're still benefiting from treatment. In fact, if you look at the study figures to the right, we know that patients who have growing tumors, despite being treated with KIMMTRAK, that they still continue to live longer than being treated with other standard of care options. And so with imaging modalities and scans that are commonly used in practice nowadays, that does raise the question about some ongoing research. Is there alternative methods for us to evaluate patients and to know if they're benefiting from treatment without necessarily relying on imaging? And so one of the topics that I wanted to discuss today is a little bit more about the research of liquid biopsies. And so what are liquid biopsies? These are basically minimally invasive tests where we can actually analyze a patient's blood, urine, or other bodily fluids to actually detect things like cancer cells or even cancer DNA or even some proteins in their blood as a marker to know, for example, what their disease status, whether it's before or even during treatment. So one of the research I'd like to highlight, particularly what we're doing at the University of Wisconsin, is that we're actually developing a new technology where we can actually nowadays successfully capture circulating tumor cells or cancer cells in the blood. Over the past several years, there's been a lot of difficulty in terms of capturing these cancer cells. And so one of the projects that we've been doing over the last several years is looking at patients, including patients with metastatic uveal melanoma. And what we've been able to do is actually successfully capture these circulating tumor cells with great purification techniques and actually being able to distinguish between what is a cancer cell versus a normal blood cell in the body. And so I obviously want to make a shout out to our research team at the Circulating Biomarker Core at the University of Wisconsin, who's really developed this technology over the last several years. And we've not only been using this for now uveal melanoma, but a variety of other cancers as well. And so, what I have illustrated here is that, part of my research is looking at the value and the utility of looking at CTCs, or circulating tumor cells, that change over time once a patient starts therapy. And so we've actually generated a great deal of preliminary results in uveal melanoma patients where a decrease in circulating tumor cells may indicate a response to treatment on imaging, and for patients who have a rising circulating tumor cell, may indicate progression or lack of benefit to therapy. But for several patients who may, for example, be treated with immunotherapy, one of the advantages and techniques that we've been able to do over the years is actually look at some of the immune proteins of these circulating tumor cells and assessing how these change over time. And so it really gives us a bit of a snapshot of knowing how the biology of the cancer changes with therapy without us physically needing to biopsy the patient's tumor during the course of therapy. One of the available and a variety of other commercially available platforms that are now available to actually assess a patient's blood and look at markers of their cancer is circulating tumor DNA. And one of the platforms I've been using in my practice is ctDNA, which is a blood-based biomarker test developed by Natera. And so just to kind of briefly highlight how this test works is, we usually have to go back to the tissue or biopsy sample that was submitted previously. The tissue is then analyzed for certain mutations and DNA alterations. But what's great about it is that you essentially individualize the particular test for that patient, that one individual. And what's great is that with that particular blood test, we can then monitor the specific DNA alteration of that patient's cancer. And so as you can see with the illustration to the right, we can actually assess and quantify the amount of DNA that is in the body at any given time point. And so, for example, you can check it before the start of treatment or even after treatment. So you can imagine with circulating tumor DNA being sort of a very powerful tool that we're using nowadays to monitor a patient for a variety of different settings, whether it's to assess for cancer recurrence, but also as a means to know if they're responding to therapy. And again, what's great about this test is that you can check this at multiple different time points throughout therapy, and could potentially be a new tool to maybe replace radiographic imaging one day. But I here wanted to sort of display sort of an example of like what type of results that your oncologist or what I'm receiving, but what I'm also able to share with the patients as well. So, for example, if you look at the DNA results of the patient on the bottom left, we see that the DNA levels are rising as they're starting on therapy, which could then entail or suggest that they're not responding to treatment. Whereas on the bottom right, we have a patient who had a detectable level of DNA in their blood, and once they begin therapy, as we're checking these blood tests, throughout their treatment course, we can see these levels become undetectable, which could suggest a favorable outcome. But overall, there's several limitations with using this particular test, ctDNA, but as you can imagine, nowadays, we're now investigating newer and novel techniques and different platforms in order to detect DNA and circulating tumor cells. And so I'll give an opportunity to Dr. Moser to also talk a little bit about CTHC as well.
I think that was a really good overview of some of the circulating biomarkers. One of the other biomarkers that I know gets asked a lot about from uveal melanoma patients is the circulating hybrid cells, and how are they different than circulating tumor cells. So we do have a couple slides which we can share, and then we can ask Dr. Moss some questions. So these circulating hybrid cells, I think have been talked about before at some of these meetings, and are really led, or most of that science is led by Dr. Scallett, I believe, at University of OHSU in Oregon. And if we can pull up the hybrid cell slides, the other slides, should only be 2 of them. Okay, he's shaking his head. That's okay. So, there's the circulating tumor cells, which Dr. Ma talked about, which are cells from the tumor that are cancer that have slipped into the blood. But we know that cancers, sometimes when they spread, they don't actually do it alone. And what Dr. Scallett at OHSU has shown is that in uveal melanoma, sometimes these cells will actually merge with immune cells, and so these two cells will come together and create a hybrid cell. And their data that they've shown and that they're still studying is that these hybrid cells, based on the technology they're using, are actually more prevalent in the blood than the circulating tumor cells, which can tend to be in pretty low numbers in patients with uveal melanoma. So they're looking at these hybrid cells, which they can more easily detect, and doing some of the same analyses that Dr. Ma and others are using, really trying to correlate, can you look at the number of cells in the blood, and does that predict if someone's more or less likely to recur after you've treated the tumor in the eye? And can you follow the number as a response to treatment? A lot of the data of the CHCs, the circulating hybrid cells and the circulating tumor cells, is very similar. So a lot of the stuff that Dr. Ma showed would be some of the same stuff that I had on my slides. But it's basically just another way of looking at the cell, but they really give you the same information of how many cancer cells are floating in the blood. So with that, any questions for Dr. Ma or myself about kind of the circulating tumor cells or these tumor-informed circulating DNA where you have to have a biopsy to create the test using the Signatera platform that he talked about?
So I had the Signatera test done, and it was positive, even though I had a very small tumor, which my oncologist was a little surprised to see that I was positive. And so we were able to use that to monitor the Ipi-Nivo response. And, I went from positive to negative after 2 treatments, but my PET scan was still showing everything lit up. And then just my last scan, so 9 months after treatment, now my PET scan is no evidence of disease again. And so it's just really exciting to think about how this can help minimize MRIs, PET scans, how it could potentially be used in the future for that. Because one of the things I do is I get my Signatera test done a few weeks before my scans, and if it's still negative, I feel, I have a little bit more reassurance that my scan is probably going to be okay, or if there's something, it's going to be very minimal. And so I guess one question I have is, and I think the answer is yes, I think you kind of answered it with Dr. Scallett, is are we looking at potentially using that, using a test like this after the initial diagnosis versus maybe not having to do scans as much, if we can get to a point where we're confident that this type of test would pick up cancer cells, just because scans can be so stressful, and, a blood test is much easier. So that's kind of my question, I guess.
Yeah, I think that's a great question, and I think there's a lot of utility that, using circulating tumor DNA like Dr. Ma showed, but one of the big problems with that test right now is you need a biopsy and more tissue on that biopsy than we typically do when someone just has a tumor in the eye. And so we need kind of an off-the-shelf kind of general test to be able to follow people after treatment of their eye tumor. And so that could be the CTCs, the CHCs, and it's actually a perfect segue into the next speaker, where they have a similar DNA or ctDNA platform that doesn't require the biopsy that could potentially kind of fill that void.
Thank you. Yes, so I'm Claudia. I'm co-founder and CEO of Oncobit. We are a small spin-off from the University Hospital of Zurich, and so that was exactly our motivation, to actually improve the monitoring of cancer, and we have a very strong focus on uveal melanoma to start with. Do I have I see something up here.
And then they should be bringing up your slides shortly. So, there we go.
Yes, perfect. So I did switch it to the I Believe Thrivership seminar, because I actually do think it's really inspiring to be here and to meet all of you. And yes, so it's really an honor. And thank you so much for letting me show some of our data and our approach. So this is exactly what we just talked about, right? What does the current cancer monitoring solutions look like? And often they are actually quite invasive, and at the same time they are also unspecific. And so once patients are being diagnosed, it's really the standard of care is still imaging, and as we just heard, it can be quite stressful, and still, it's, at the moment, that's really the method that is out there and that's most commonly used, and it comes with its limitations. So, depending on the scan that you're getting, you're exposed to a lot of radiation, and some of it is unnecessary, right? Because at the moment, scans are used because there's no other alternatives out there, or at least that's still the standard of care. And they are not necessarily used to localize the cancer, they're really used because no other alternatives are being used. And what we've seen, for example, also during the COVID pandemic, sometimes these scans were positive when you got a COVID vaccination. So there are some limitations, right, when it comes to these scans. And because of this, they're only performed, and the cost they are associated with, they're only performed every 3 to 6 months. And so during that time, right, I mean, depending on the stage the patient is, this is sufficient to monitor every 3 to 6 months. But sometimes, if you want to see if you're responding to treatment, maybe you want to monitor more often, more frequently. And those are then the limitations when it comes to imaging. And that the monitoring is limited. That means that the patients are sometimes wrongly treated or often also over-treated. And this, of course, leads to unnecessary side effects and, of course, also unnecessary costs. And so that was really the motivation why we wanted to look at that differently. And so I just already got the perfect introductions by my previous 2 speakers. So we use also liquid biopsy to assess this. And I just also want to highlight some of the cons that come with this approach. I think they were also touched upon earlier in the earlier sessions. But there is a lot of heterogeneity when we look at circulating tumor DNA or circulating tumor cells. So this depends on the treatment, it depends on the stage, it depends on where the cancer has spread, and this makes it sometimes very difficult to interpret that data, and that's definitely one of the limitations when it comes to liquid biopsy approaches. At the same time, we don't know where the tumor is coming back, right? Let's say if we do see circulating tumor cells or circulating tumor DNA come up, we don't know where they originate from. So we will never replace scans, right? We need them to localize where the tumors are, but maybe we can help guide them to when they're actually needed. But there is also some important pros when it comes to these techniques. And so this is also something that we heard earlier, that whatever you detect in the blood is really like a cross-section of the cancer of your body, right? So if you have, for example, multiple metastases, they might have different cancer markers, different mutations, and all of this is sort of like reflected with what you can find in the blood. And of course, they're minimally invasive, as we heard, so it means you need a blood draw, right? And so that enables actually relatively frequent testing during the stage of the disease. So we also already heard that 2 most frequent ones are circulating tumor cells and circulating tumor DNA that you can look at. And so circulating tumor DNA is what we focus on. And the reason why we can do that is because in the DNA you have these mutations, these markers that we heard so much about in the earlier sessions, and we can then specifically detect those cancer mutations and markers. And even though we now know what we have to look for, these specific markers, it's really like looking for a needle in a haystack, because also, as we just heard, right, in the DNA in the blood is not just tumor DNA, it's also a lot of normal DNA that comes from blood cells, from immune cells, and so that means that the tumor DNA or the circulating tumor DNA is really diluted in this other DNA. The second point I want to make here is that the more tumor DNA you have in the blood, typically that's a worse sign, right? And so that means that we want to, and others and also we have seen that as the cancer progresses, the more of this DNA we find in the blood. And that means that we actually need to the methods that we want to use, they need to be on one hand very sensitive, right? We really want to detect this needle in the haystack, but at the same time, we also want to know how much of this needle we have. And so we need sensitive and also very quantitative methods to do that. And essentially, there's two different methods that you can use, and we've heard already quite a lot about this. On one hand, sequencing. So this means that you look at many mutations at the same time. It's a little bit more costly and also more time intensive because of that. And then the other method that I want to focus more on is PCR based. We use something that's called digital PCR. I go a little bit more into detail into that in a little bit. And here we now really only focus on very few mutations, or even just a single mutation. And that makes it a lot more cost and time efficient. And the reason why uveal melanoma particularly is a very good case to use PCR is because more than 90% of patients have mutations in gene AQ or gene A11. So it's really, if we can just follow these two mutations, we can cover already a lot of the patients, and that's why it's a very good solution here. And that was sort of the rationale for founding Oncobit as a spin-off. And we have developed this platform technology called PM, Personalized Monitoring, where we want to monitor the cancer with a simple blood draw based on the quantitative but also very specific detection with this very sensitive method called digital PCR. And because of that, it's very cost and time efficient. So really what we want to enable is a very tight monitoring of the cancer, of the therapy response. And what was also very important to us was that it is accompanied by a software. So the more data you generate, right, and we're talking about very sensitive methods here, it requires a very standardized analysis. Otherwise, you're going to get different results depending on where the test is performed. And so this was quite important to us as well, and that's why that's a very big component of our product. And so it really exists of two components. And so our test can actually run anywhere in the world. So we can just, because it runs on existing infrastructure that's typically in place in large laboratories. And so we can ship our kits to these laboratories. The test can then be performed there, and the data that is generated can be uploaded into our cloud, where our software that was trained on healthy and on patient data can then analyze and interpret the data. And so the way we envision monitoring now is that at the time of diagnosis, of course, a gene expression profiling test is performed, for example, CARIS or also Castle from the one from Castle, where also these markers are typically identified, and we can then choose our kit to detect the very specific marker we know now the patient has, and follow the patient very frequently with our monitoring solution. And then once the test becomes positive, of course, we still need a scan. Right now we need to localize where the tumor is, but we can hopefully guide in the future when these scans are needed. For a less invasive but also tighter monitoring, and ultimately a more data-driven therapy management. So I do have some additional details on digital PCR. I think we have. Do you want me to go?
Yeah, we still have 20 minutes.
Yeah. Okay. So the way that the workflow works is really that the blood is collected and the DNA is extracted. We then put that DNA together with our kit into something that's a little droplet. And you have to imagine this almost looks like a vinaigrette. So you have an oil phase, and then you have 20,000 tiny aqueous droplets. And in each of these droplets, we put the DNA into, and that's why it's called digital PCR. So it's compared to a regular PCR, it just means that you don't measure once, but 20,000 times, and you do that in these tiny little droplets. And the reason why we do that is because it makes it more sensitive and more quantitative. And in these droplets, you then perform a regular PCR, and PCR just means amplification of DNA so that it's easier to measure. And in each droplet, we then have the droplets then start to glow green or red, depending on if we have cancer DNA or normal DNA in it. And we can then measure these droplets, or we measure if they are glowing. And that data is then analyzed and interpreted by our software in the cloud. And what you get back is a report. And I already mentioned that the first part, so really from DNA isolation to droplet reading, can be performed in any laboratory that has the existing infrastructure. The analysis is then always performed in our cloud to ensure this standardization that I already mentioned. And what comes out is a report. So because we only look at a single mutation, right? We just follow one marker. It's actually much easier to interpret and to understand than other reports. So essentially, what comes out is a call. So is the sample positive? We need more than one molecule. So really just 2 pieces of DNA are sufficient for us to make that call if the sample is positive. But it can also be, of course, not detected or failed. We also output the concentration, so it is quantitative. So how much of the DNA is actually cancer DNA? So that's the output of our test. And it also comes with error bars, so confidence intervals. So how certain are we of the amount that we measure? And then one important warning, for example, that comes out from our software is if there is not enough DNA that was detected, and that's one of the limitations of liquid biopsies, then you need to be more cautious, right, with interpreting that the test was not detected. So this is something to always keep in mind, right? Every method has its limitations, and that's one of the limitations of liquid biopsies. So these are, for example, examples. So we also just saw that from Dr. Ma, like how this could look like if, for example, the patient is always negative for circulating tumor DNA, so as in the upper graph. That's a very, very good sign. So we've seen also metastatic patients that are just for years negative, and those patients perform really, really well on different types of therapies. If, for example, the patient is initially positive but then decreases, the circulating tumor DNA decreases, as in the plot below, that's also a very good sign, right? The patient is responding to therapy, but then, of course, once the therapy has, for example, stopped and the circulating tumor DNA comes back up, right, then it's important to intervene early again and to maybe select a different therapy. And so one of the studies where I just want to show a little bit of data is a retrospective multicentric study that we're doing with the University Hospital of Zurich, the University Hospital of Hamburg, and also Mass General has sent us some samples. And here what we can see is, so these are complicated plots, but I hope I can guide you through them. So the blue curves are patients where we don't detect any tumor DNA. The yellow patients are patients where we do detect tumor DNA. And then on the left side, you're looking at the probability of overall survival, and on the right side, you're looking at the probability of progression-free survival. And progression-free survival here means imaging. And the reason why the left and the right plot look different, that actually illustrates the limitations of imaging. That sometimes the scans are positive, but it's not so meaningful that they're positive because they may be false positive. But what you can tell is that your overall survival probability, so the blue curve, right, is much higher than the yellow curve. And that means that if you are negative for circulating tumor DNA, right, that's a very good sign. And it just increases the survival probability is a lot higher in this case. And I think with that, I'll probably stop here. And
looks like Kevin has a question.
Your test is unique because you can take a sample of blood from a uveal melanoma patient and look specifically at GNAQ or GNA11 in that blood sample and then look at it in their circulating DNA using your technology. So this is, I guess, what we term off-the-shelf type of technology. You don't need the prior tumor sample from the original biopsy. Is that correct?
Yes.
Okay, this is That's very interesting. Okay.
So the idea is really that, so we don't need a prior biopsy. As long as we know which marker the patient has, then we can look for exactly that marker. And that's why in uveal melanoma it's so easy for us, right? Because almost all patients have these two markers, GNAQ or GNA11. Yeah, and because we really just focus on that one marker, right, that makes it so much more cost and time efficient. Yeah, so that's the idea exactly, to simplify the whole thing.
Great question. Any other questions?
Yeah, I'm like, can we turn Dr. Moser's mic up a little? Thank you.
Great question. There we go. Any other questions?
Is this available now?
Is this test available now? Okay.
So.
I have tried. I can tell you that.
He's tried. He's very good at trying.
So we have regulatory approval in Europe already, and it's implemented in the first hospitals in Europe where it's now in clinical routine. We're trying to, so we are a small, we're 10 people, so we're a very small company, and we're trying to get it to the US as fast as possible. So we're right now looking for laboratory partners to make it available here. We're also like very open for studies, and because that's easier for us, right? If the samples are shipped to us in Europe, we have a laboratory in Europe where we can analyze the samples. But right, you want to know the turnaround time, right? That's the advantage of this test, that it's quick. And so it only makes sense, of course, that we then have a partner here in the US where we can actually then analyze the samples quickly rather than shipping them all the way to Europe and with all the complications that this comes with. Yeah.
Lucy, you have a question?
How much would it cost patients with or without insurance?
Okay, cost for patients with or without insurance.
Yeah, so
and shipping and all the things.
So our test is going to be the smallest fraction of the cost compared to how much it costs to perform the test, right? So it's just a little bit more cost, or it takes a certain time to perform the test in the lab, and also some additional reagents that are needed, and that's actually going to be more expensive than our test ourselves. So in Europe, it's right now it's a couple of hundred, but it's in the US it will depend a little bit, right, on the partner that we find. Mm-hmm. Yeah.
Unfortunately, most things in the US tend to be more expensive than Europe just because of our infrastructure. So I would not expect a couple hundred, unfortunately.
So there would be. So once we do have a partner that is accredited for this kind of procedure, it might actually be available much sooner than if we have to go through FDA approval. So that's one of the options that we're exploring right now. There was unfortunately a recent FDA ruling in June that makes this now more difficult. But we're still exploring, like we're talking to a few laboratories to see if we can still use this path. And there would be a reimbursement code for around 500. And so I think also in the US it should be possible to make it, or like to be covered with this code. So that's still one of my big hopes, that we somehow can use this code. But yeah, it's...
I mean, I'm a fan. This sounds great. This sounds great. Can all of these tests be like this? Okay, do we have any other questions from the audience? Any other comments? I'm like trying to look around my podium here. It's great. So if we're going to Europe, we just find you, Claudia, right? Okay. Reasons to go to Europe. 1, 2, 3, 4, and 5. She's number 1. Okay, so the question was, is one test adequate, basically? Like, could this be helpful, or is it more productive to do the test repetitively, like alongside scans every 3 months, 6 months?
So what we also heard earlier, right? It's a snapshot that you're getting. So it's sometimes we've seen some variability. I mean, in general, if the test is negative, right, it's a good sign. If it's positive, then maybe more tests should be performed more frequently. But typically, we want multiple tests done because it's just a snapshot, right? And
And we can throw this to Dr. Ma online, but Dr. Ma, is there any setting where you would just send one of these tests, either circulating tumor DNA, circulating tumor cells, where you think one test would be informative if you could just draw one?
Yeah, that's a great question. I mean, as of right now, we're still trying to understand if these tests are, valid, so to speak. And we're still complementing these tests with imaging. But as of right now, for a lot of patients that I see who are very interested in sort of advancing our knowledge and the research of liquid biopsy, many of them are participating in both ctDNA and circulating tumor cells. And, one of the advantages of doing it this way is that it helps us better understand the correlation. For example, if we're seeing rising circulating tumor cells, do we see that same correlation with rising circulating tumor DNA as well? And then how does that correlate with imaging? And so, as of right now, especially as we're developing a lot of these new liquid biopsy assays and tests, further validation still needs to be done at this point. And, how does this correlate with long-term outcomes for patients? How are patients, are they living longer as we're using this as monitoring? But I know earlier what was posed by the audience was that, this test can be used for more of just monitoring, as another means to also provide some anxiety relief for patients as well. Knowing what their DNA levels or CTC levels are during the course of therapy, it can also provide some reassurance and some confidence in the treatment plan for the oncologist as well. But so to speak, at this point, I think we still need some further research into using these tests, and very excited to see about sort of the variety of platforms that are existing out there.
Thank you, Dr. Ma. So this question is it helpful to do a CTC, ctDNA in conjunction with the imaging? And I think the answer is yes. Yeah, I'm getting lots of nods from everyone. So, one of the ways, if you think about like a graph, right? Like just a basic math graph. If we have one data point on the graph, that doesn't tell us a whole lot. If we have 5, we have trends, right? And trends are something that we can look at, well, our doctors can look at, we can look at with our doctors. I love trends. And so seeing those trends happens with repeat tests. It correlates to then the imaging, like it's all of these different data points on a graph. And if we have more of them from doing more frequent testing, then the information could be posed as, potentially more reliable. We could hypothesize that for that patient, this is what that trend says. But we can't do that if we only have one test. We need a few or, multiple to start to see that pattern and see if it matches. And so, let's go back to biopsies, right? The more information we can get about our disease, the better. So if you have the opportunity, your doctors can run this test, your insurance will run any kinds of these tests. There's so many different avenues of how it can help us and how it can help our doctors. So I think that's important to note that it is helpful if you can do it.
Yeah, this is exactly what we're doing now in all the studies. We're collecting as much data as possible, imaging data, but also sometimes other blood markers are measured, and we correlate all of this, right, to also the circulating tumor DNA. And then maybe in the long run, right, it will help us to, for example, reduce the scans or to, yeah. But
because wouldn't that be beautiful to not be stuck in an MRI tube every 3 months and be able to just do CTC every 3 months and be reliable, or ctDNA, and have it be reliable based on the data enough that they could say, yeah, we can scan you every 6 months instead, or whatever the frequency turns into.
And we're still getting a lot of the data in Uveal.
Can we check Dr. Moser's mic, please?
We're still getting a lot of the data in uveal, but in other cancers, we have shown, such as Merkel cell, that the blood ctDNA-based test will turn positive 2 to 3 months before we'll find it on a scan. And so in other cancers, we know that this may be better. We think that's going to be true for other tumors like uveal. We just don't have that data yet, but that's why it's important that we continue to do these studies.
Thank you. Claudia, do you have anything else to add?
No, exactly.
Yeah, it's awesome. All right. Well, you guys, I think we're coming to the end of questions. So unless we have any other pressing questions from the audience, I know this is such a fascinating subject. Dr. Moser, have you presented yet? I'm sorry if I didn't see. Did you get to talk about hybrid cells yet?
We just did ad hoc.
Okay.
Yeah.
Awesome.
We didn't have slides, so we're good.
Okay. Sorry. Had to catch up in my, where are we at right now? So if you guys don't have anything else you want to say to close out, I think we're good. Anyone have closing remarks? Okay, well, you guys were doing awesome. We are ending early, and if you are ready here in person, we've got lunch outside. But before we do that, I need you guys here in person to vote. It's a really hard decision, I'm sure. We're going to be doing our dinner, and it's this evening. We're going to have the dinner from 5:30 to 8:30. We've got cocktail hour, 5:30 to 6:30. Dinner is served at 6:30. However, the weather right now is clear. We have no rain, but the weather is showing we're going to be in the high 60s for the evening from about 5:30 on. So currently dinner's planned to be outside. By vote of hands, if you want to be outside instead of inside, raise your hand if you're good with outside knowing the temperature. Okay, votes, because we're going to move to inside if we would prefer. Okay, I'm seeing very few people. I want to be outside, but no pressure. Inside, we would be down in one of the ballrooms. I'm not sure which one of the rooms we would be in, but inside we would be in the hotel. So if you want it to be inside in the hotel for you to dress up, come hang out, then we need to let the hotel know. So vote of hands, who wants to be inside? And who didn't vote? All right, okay. So I saw more hands for outside. Raise your hand for outside again. 1, 2, 3, 4, 5, 6. I'm counting like 6 or 7. 7, 8. Me. Okay, and inside. Vote for inside. It'll be like between 60 to 69 is the range, and so by 8:30, it's going to get down to like 60. So, does anyone want to amend their vote? Inside again. Vote. We don't have the ability to have the heaters because they will. The hotel charges for those things, and it's not a cheap fee, unfortunately, and we're a small nonprofit. They don't seem to understand that. So, jackets, coats, Arizona people, we can wear a coat. I want to wear a coat. Okay, all right, so I think it's sounding like I have my vote higher for outside than inside, so I will let them know in that room, and we'll see where we're at with numbers. Just stay tuned. We'll be back at 1 p.m. for our next session. For now, I'm just going to say thanks again to our partner sponsor, Trisalis Life Sciences, and we're grateful for their sponsorship making this possible to bring you this seminar. And then I need my clicker. Can I borrow that? Thank you. Again, 5Ks. Dr. Mosier and I are hosting the 5K Looking for a Cure here in Scottsdale. It's the third one we've done in Scottsdale, and we are thrilled to have representatives from Castle and I believe Aura Biosciences, and it might even include Delcath. I don't know. Any of our pharma reps who come, we are so glad when you guys come to the 5Ks. But again, tell your friends and family, tell them about these dates, and have them go register. If they can't register, then please encourage them to donate instead. We just talked about dinner. We'll see you guys tonight at dinner at 5:30. Dress up as much or as little as you'd like. And if we are going to be outside, which I'll let you know in about an hour and a half, then just plan for a little light jacket if you need it. Okay, so we're on to lunch. You guys have an extra 10 minutes for your lunch hour. We will be back in this room for all sessions. So if you're online, you're going to join to the next available stream at 1 p.m. after our lunch break. We'll see you guys soon.